at least I hope so, in this session, and our timetable will be tight. We have both 8 minutes and brief 4 minutes presentation. The first 7 presentations last 8 minutes each, and the remaining 8 presentations last 4 minutes each. Because the schedule is so tight, we probably won't have time for questions or comments, or maybe we do. Therefore, if the audience have any questions about the presentation, please contact the speaker afterwards, or if we have time left, then we can ask them after some presentations. Before each presentation, I will present shortly the speaker and the title of the presentation. I apologize in advance that I probably cannot pronounce the names of all the speakers correctly, but I will do my best. So, our first speaker is Neda Kapiri, and the title of her presentation is Policies to Tackle Bacterial Resistance, a systematic review of text and opinion. The floor is yours, Neda.
Good morning, ladies and gentlemen. Is the sound okay?
Yeah, the sound is okay.
Okay. First, let me introduce myself. I'm Neda from Evidence-Based Medicine Research Center in Tabriz University of Medical Sciences from Iran. I'm delighted to be here today to make you a presentation about our research with the title of Policies to Tackle Bacterial Resistance, which was a systematic review of text and opinion. This was our research team, and I want to thank to dear Professor Haj Ibrahimi because of her full support of this research. Let me start with a short introduction about the topic. As you know, the discovery of antibiotics have contributed to major improvements in health and decreased deaths from infectious diseases. However, high rate of antibiotic use due to increasing incomes, increasing hospitalization rate, and raising prevalence of hospital-acquired infections continues to be a threat worldwide. This systematic review of text and opinion conducted to investigate expert opinions, thoughts, and conclusions about combating bacterial resistance. We adhered JBI guideline for the review of text and opinion. So for inclusion criteria, as participants, we included patients using antibiotics and healthcare providers prescribing antibiotics. As a phenomenon of interest, this review considered publications described expert opinions to combat bacterial resistance. As the primary consequences of this systematic review, we included policies that had reduced bacterial resistance, and finally, for types of publications, we only included expert opinion, discussion papers, position papers, and other forms of text, all published in the English language. As you see, we searched databases, searched Synthesized, Web of Science, and other databases for published text. Also, we searched ProQuest and NDLTD for Gray literature and...
Sorry, yes? Neda, could you please open the presentation in large mode?
Yeah, like, yes,
so
sorry.
Everyone, yeah.
Is it okay?
Yeah, that's okay.
Yes, thank you.
Thank you.
Yes, we searched ProQuest and NDLTD for Gray literature and unpublished texts. For assessment of methodological quality of studies, we used JBI narrative, opinion, and text assessment and review instrument. Also, 2 independent authors assessed the methodological studies. For data extraction, again, we use a standardized data extraction tool from JBI that included 4 items: specific details about policies, populations, context, and the type of text. For data synthesis, we read and reread the text in order to identify the meanings of the content and to draw conclusions. The conclusions were presented in narrative form. I just want to move to the results section, being 18 texts in the systematic review of text and opinion. Represented target population in the documents were patients, prescribers, policymakers, hospital managers, and governments. As you see, this is our Prisma flowchart. We finally included 18 texts in this systematic review. I would like to illustrate the main results by showing you this table. In this table, we summarized the core policies for tackling bacterial resistance. As you see, we had 5 population groups: as governments, hospitals, prescribers, public, and we had use of antibacterials in food-producing animals. And these were our policies, as you see in this table. In conclusion, let me sum up my main points. As the findings of this systematic review showed, governments, through some policies and strategies, can control bacterial resistance. These policies include setting up antibiotic surveillance programs, legislation for antibiotic prescription, developing and implementing national guidelines, and above all of them, improving home hygiene, which should be strengthened by educating and informing public. That's all I have to say about, and I'm happy to answer if there is any question. Thank you.
Maria, please, could you open your microphone? Estaba hablando ella.
Sorry, my mistake. So thank you, Neda. I don't see any comments or questions in the chat, but maybe later you have some questions for her as well. So we can continue. And our next speaker is Ilaihe Hahkos-Eile. Her presentation concerns improvement of violence management among nurses in Shahid Beheshti Hospital in Iran. This was a best practice implementation project. And I'm sorry about my pronunciation, Ilaihe, but the floor is yours.
Hello, everyone.
Is Ilaihe?
Elahe. My name is Elahe.
Okay, it's your turn.
Can you hear me?
Yours.
Can you hear me?
Yes, we can.
You have to share your screen for sharing your presentation.
I can share my presentation. Can you help me?
On the bottom, on the bottom of the application, you have the option of share screen. On green.
Okay. Just a minute. زدم دیگه اینو. فایس نمیاد آخه. Dropbox ندارم من. Sorry for late. Excuse me, I can't share my presentation in this webinar, in this symposium.
Are you able to find the option of share screen on the bottom?
Yes, I find share screen, but the item is Dropbox, Microsoft OneDrive, Google Drive Box, and Microsoft SharePoint.
You have to have your presentation open on your computer.
Okay. Okay.
Once you have your, okay, that's right. Yeah, perfect.
Is it shared?
I think it was shared, but now we only see you. You have to have your presentation open, then share screen and select the window in which you have the presentation.
Okay, sorry for late and...
Don't worry. We will adjust the time.
Okay.
Sorry, Elahe, are you having any problem?
Yes. I can. Can you see it?
Yeah, now we see.
Sorry for late.
No, don't worry. You can start.
Okay. Hello, everyone. My name is Elahe. I'm assistant professor in Maraghi University of Medical Science. Today, I'm going to talk about violence against nurses in Shahid Beheshti Hospital, a best practice implementation project. My presentation will be 3 parts. I'll start with the concept of violence and prevalence of workplace violence. Then I'm going to talk to you about methods, and finally, I'm explain results and discussion. Let me start with some general information about violence. Violence is one of the most important issues in public health that most people have experienced in their lifetime. Definition of violence is different from person to another person and between groups, cultures, and countries. Violence that occurs in the workplace is called workplace violence. Violence at work has become an alarming phenomenon worldwide. We have to remember that workplace violence is a major problem affecting health and productivity of healthcare workers. The World Health Organization classifies violence into 4 categories: physical, verbal, racial, and sexual. Increase in violence and conflict in the workplace is considered as one of the great concerns of the nurses in the workplace, which is increasing in the hospital and clinics. It's a complex occupational hazard. It should be emphasized that it is a managerial issue, that by transforming the work environment into an insecure and hostile and influence the performance. Several lines of evidence have reported that more than half of the nurses in European countries have experienced some type of violence in the workplace. We note that the rate of workplace violence is higher in Asian and Middle Eastern countries, where more than 2/3 of nurses were exposed to violence. The evidence showed the prevalence of verbal abuse and physical abuse in Hong Kong hospitals was 13% and 80%. Also, in Canadian hospital in Alberta, nearly half of those survived has experienced one or more type of violence in the last 5 shift works. In Iran, more than 70% of the nurses had an experience of violence during their work period. To sum up, the effects of violence are wide and varied, including increased absenteeism and sick leave, property damage, decreased productivity, and so on. Let's now turn to audit question. In this study, we have audit question. The audit question was, what is the prevalence and nature of workplace violence against nurses, and what can we do to decrease the violence against nurses? In design, we have three phases of activity: establishing a team, designing and implementing strategies, that was baseline audit, and conducting a follow-up audit to assess the results of intervention. In this study, we used different tools and different methods for gathering data and analyzing data. The current study was conducted with JBIEU Hospital. It's a general hospital, and in hospital have 112 beds and 114 nurses. We used RASO for sample size, and there were 86 nurses involved in the baseline audit. In this study, we use mixed method and the descriptive analysis for quantitative data and content analysis for qualitative data. As I said at the beginning, we have three phases in this study. Also, we have three evidence-based criteria. That criteria were healthcare staff receive aggression management training, 2, health staff who experience violence receive timely support and assistance following the incident, and in 3, the health organization has a policy for risk management and ensuring a safe environment for all staff and consumers. If you look at this chart, you can see that 49% compliance was reported for aggression management training, and 8% compliance was reported for the timely support, and also 22% compliance for criteria 3. After phase 1, the team adopted a bottom-up approach and presented the baseline audit to the nurses. Based on the results, the team asked some nurses by conducting focus group discussion, identified obstacle, barriers, or gaps to the low compliance of the identified criteria. If you look at this table, you can see we have 4 columns: barriers, strategies, resource, and outcome. We achieved 3 barriers in this hospital, like lack of reporting mechanism, a lack of violence prevention training program, and unsafe work environment. We designed strategies and used many resources to solve the problem to achieve the outcome, like increasing job satisfaction. And the phase 3, in criteria 1, we reached 81% compliance, and for timely support and assistance following the incidents improved by more than 70%, and in criteria 3 improved from 22% to 73%. This project, in the first attempt to examine the current practice and implement evidence-based violence management in JBIEU Hospital in Maroc. The first criteria, 81 compliance, we used a training course like communication skill, stress management, and so on. And other studies showed that 90.9% of nurses has agreed with continuing education to deal with violence and has continued is necessary. Regarding the second criterion, preparing educational pamphlets on employees' rights and preparing poster was performed in wards that showed 73% compliance. Therefore, having clear instruction and awareness of related process can lead to violence management in the hospital, and strengthening security measures, restricting visiting hours, review of security teams' responsibility were strategies that we used in hospital. Also, the evidence showed that this strategy of reducing violence in the workplace of nurses working improved the security of hospital, improving. In conclusion, based on the objective of this project, this study has been able to use some of the best available evidence and design strategies. We implemented training course on violence management and communication skills. Also, our team created a safe environment in the hospital and designed communicating guidelines for deal with violence at work. Finally, this strategy led to increased nurses' awareness, change performance, increase their resilience, and ultimately improve the evidence-based violence management. In limitation, like other studies, there were limitations in this project. The most important limitation faced by the project team were the outbreak of COVID-19 that increased the workload of nursing and which led to decrease in their involvement in training course. Also, sessions were held online because of COVID-19, and finally, our target group was only nurses. Thank you very much. Thank you for attention.
Thank you, Ilahe, for your very interesting presentation. This is one of those topics which I am very interested in because my background is in psychiatric nursing. But I don't see any questions or comments just now. Maybe we have them later, and therefore we can go for far. And our next speaker is Deborah Edwards. His title is Technologies to Facilitate Remote Rehabilitation of Adults, an Umbrella Review. So, Deborah, it's your...
Welcome, everybody. I'll just share my screen. Okay, so my name's Deborah. I'm a research fellow at the Wales Centre for Evidence-Based Care, and I'll be talking through my umbrella review today. This was our team, and this project was funded locally by Welsh Government. We've got no conflicts of interest to declare to you today. So if I start with the background, this is a COVID umbrella review. So we are aware that long-term rehabilitation needs of people who are going to have COVID are directly going to be impacted, and they're on the increase. Sorry?
Yeah. We are not seeing your presentation, please.
You can't see my presentation?
No, we cannot.
Oh. My screen is sharing. Hang on. Okay, hang on.
Hi, have you pressed the share screen button?
Yeah, hang on. Let me try again.
Yeah. Now.
Wrong screen, hang on.
Yeah, now.
Just love technology.
Yeah.
Hang on. Is it sharing?
It's all right. You can use a large mode, open the large presentation.
Okay. Is it sharing now?
Now it's perfect. You can.
Okay, sorry about that.
Thank you.
Okay, hang on. Is it still sharing? Yeah, good. Right. Okay, so I was just saying that my name's Deborah. I'm from the Wales Centre for Evidence-Based Care, and it's an umbrella review. So if we just look at the background, just to recap, we're looking at rehabilitation in people who've had long COVID. But in order to explore that, we were looking at a number of other conditions, because we know that there's going to be a increase in demand on rehabilitation services during this season, and especially care that's delivered at home, because lots of people's care has been paused, or there's delays in people receiving diagnosis and treatment. Okay, so our particular review question is, what was the evidence for technologies defined as devices, tools or software used to facilitate remote rehabilitation? And this is such a large volume of different conditions out there. We have a stakeholder group involved in the project, and based on their individual expertise, we decided to focus on adults with deconditioning, musculoskeletal conditions, stroke and traumatic brain injury. And we wanted to know what technologies exist and what are the effectiveness of these technologies in the healthcare setting. So we looked at musculoskeletal conditions, inflammatory arthritis, osteoarthritis, joint replacement. We also looked at people with stroke and brain injury, and as I said, older adults with deconditioning. We decided to focus on technologies that were defined as any tool, software or application that could be used remotely to measure, monitor or record patient data. So this included wearable devices, sensors, apps, gamification, non-immersive virtual reality, and that included things like the Wii Fit, the Xbox or the PlayStation Go. And our comparators were usual care or control group. So the context was any rehabilitation done outside the clinical setting, in the home or in the community, without direct face-to-face clinical supervision. And this was the most challenging of the inclusion criteria, because when we looked at systematic reviews that had previously been conducted, they tended to include a range of settings. So they weren't just in the home, they would be home and clinic or home and the lab. So whereas we thought we'd have a lot of systematic reviews to include, this quickly became whittled down. So what were our primary outcomes? Our primary outcomes were physical activity, which was measured the number of steps you did a day using a pedometer or accelerometer, or moderate to vigorous physical activity, balance and gait, physical performance, functional performance. And our secondary outcomes were levels of pain, cognitive function, quality of life, and adverse effects. So we decided to conduct an umbrella review because of the initial search of the literature. There were so many primary studies, and the funders had a really short time frame in which to answer their research question in order to apply the evidence to a COVID population. So we looked at systematic reviews, and we decided that they needed to ask a clearly focused question. They needed to have conducted a comprehensive search strategy with at least 2 databases, provide us with a list of keywords, and have conducted a risk of biased assessment. So we were quite strict in that sense. So we used the standard JBI methodology for umbrella reviews. We registered our protocol on Prospero and reported according to the PRISMA guidelines. So we decided to search 5 databases only for the past 5 years, because technology changes so fast and is changing all the time. So we went from January 2016 to December this year across Medline, PsycInfo, Synthesized, and the specialist physiotherapy database, Pedro. We conducted critical appraisal using the standard JBI tools, and extraction again using the standard tools. And to speed things up, we summarized all our extracted data into table form with lots of supporting texts. So we had 1,205 potential records. After we deduplicated 425, and at the end of all that long process, we just ended up with 5 systematic reviews. So what seemed a massive field because of all our exclusion criteria. So if we were looking at people with stroke, for example, we just wanted to know about people with stroke, and quite often the population samples were mixed and all the results pooled together for a variety of neuro conditions. So it made it quite challenging. But to be honest, we were glad we had only had 5, because we've decided that an umbrella review is really hard work and 5 was enough. So what types of technology did we find? We found mobile apps for post-stroke rehabilitation, and then these usually compared to a control group or a passive control group, which was either usual care, waiting list, or health information. We also had a range of computer-based activities for stroke rehabilitation, and these were usually compared with, again, with standard care or no control. We had what we've called home-based non-immersive virtual reality for stroke, and these were your Wii Fit, where you kind of do balance exercises on your Wii Fit board, which you could quite easily do at home. We had the wearable activity trackers for the older adults with deconditioning. These are things like your Fitbit, your Garmin that you wear on your hand and are linked to the computer or a mobile application. We had a number of web-based applications for rheumatoid arthritis, and sometimes these were combined with information, social support, and online groups. And then we had electronic health supported, which were web-based or app-based with wearable trackers for home-based interventions for osteoarthritis in the knee or hip. So even though we had a broad range of conditions to include, and the reviews only covered stroke, rheumatoid arthritis and osteoarthritis, there was nothing found for traumatic brain injury. So what did we show in terms of effectiveness? We found that computer-based activities were beneficial for improving cognitive function, but were no benefit for quality of life for post-stroke rehabilitation. Interventions that included wearable activity trackers. Now, these gave mixed findings. The individual studies within the reviews, half of them would show that it worked, half of them that showed that it didn't. Because then a lot of the time, the control group were also given a wearable activity tracker, but with no extra information. And just the fact that the control group were wearing the activity tracker meant they were kind of thinking, I need to increase my physical activity. So there was no clear benefit over the control groups for people wearing activity trackers. Everybody's activity increased in a sense. If we look just at mobile apps, they were beneficial for increasing levels of physical activity and physical or functional performance for post-stroke rehabilitation. If we look at the web-based rehabilitation, the issue with these is that they contained a variety of components. And so across all the different studies, across all the reviews, there was not one rehabilitation that was the same. Some had lots of contact with the health professionals, some had none. So it was really difficult to compare across studies. So they didn't show any effect in physical performance, quality of life, reducing pain, or increasing levels of activity in individuals with rheumatoid arthritis, because it's really hard to pull out the technology component of a wider intervention. So if we look at those interventions that help people with osteoarthritis, they were effective in improving physical performance and reducing level of pain. So they were wearable app-based interventions with wearable activity trackers. And the final one, a therapy in the form of screen-based non-immersional virtual reality, which is the Wii Fit. It was found that rehabilitation can be successfully transferred to the home environment for improving balance or gait on individuals with stroke. And in this systematic review in particular, they compared doing the Wii Fit at home and doing the Wii Fit in a clinic. And in effect, they had the same answers, so that care could be transferred successfully to the home environment. We were unable to grade the quality of the evidence because the information wasn't provided in the individual systematic reviews. And based on JBA guidance, you're not meant to go back to the primary research and work it out for yourself, which we were quite grateful of. But it does mean we have quite a lot of low quality evidence in order to answer the question. So, and lots of limitations for this. And I think in doing umbrella views in general, that there was such great heterogeneity in the interventions in the populations, it was really hard to find things of similarity to do the work. Rehab was conducted, even though it said remote, people's definitions of remote was different. So you might have a couple of sessions in the hospital and then go home to do the rest. You might meet in a community hall, you might meet at home, or a number of reviews didn't actually state their setting. As I alluded to, the majority of cases and reviews where technology was used part of wider intervention, so it was hard to unpick. And a lot of people pooled their results across all technologies. So you might have a review specifically looking at the Wii Fit, or you might have a review that looked at a whole range of 5 or 6 different immersive and non-immersive technologies and provided their results all together. So in summary, there were only a small number of systematic reviews that we could unpack of low quality evidence, and the individual studies in them were also of low quality. So it was difficult to make conclusions. But it does show that there is this great need for high quality evidence in the field of rehabilitation and technology across all population groups, especially now in the wake of a post-pandemic environment. Thank you.
Thank you, Deborah. We have one question for you. Someone is asking, umbrella reviews are still a relatively new methodology. How did you find doing one?
We actually said we never want to do one ever again because it was really difficult. It's such a challenge. I can see the benefits of it, and they are quite complicated, and it is really annoying when you're trying to extract data from a systematic review and the information's not there and you don't have the time to go back to the primary studies. And especially now in the COVID era, we're noticing that a lot of reviews are coming out. I've done really quickly, they're of really poor quality, and the information just isn't there for you to extract. Something as simple as an included studies table, people weren't put in the countries where the primary research was conducted. And to me, that's quite a basic feature to put in your included studies table, but you couldn't even report some of the basic information. So it's a very frustrating form of review.
Thank you. And Ilahi, there is a question for you in the chat. Do you want to answer it through this chat or? Ilahi, the violence and aggression presentation, can I ask, do student nurses have training? Ilahi, you don't have microphone open. Okay, maybe later. Thank you once more, Deborah. Very interesting process, I guess so. And then we have next speaker, Neda Kapiris. Second presentation is Cancer Management in COVID-19 in Iran. This presentation based on qualitative systematic review of challenges. Neda, it is your turn.
I'm here. Hi again to everybody. This is Neda, and I'm going to make you my second presentation with the title of Cancer Management in COVID-19 in Iran, which was a qualitative systematic review of challenges. This was our research team. And let me start with a short introduction about our topic. As you know, non-communicable diseases are one of the leading threats to health and human development worldwide, particularly in developing countries. Since the emergence of COVID-19 and the rapid spread across the globe, all determined targets and actions to prevent and control NCDs have been shifted to COVID-19. The relationship between these two epidemics is multifaceted, as NCDs are the major risk factor for COVID-19. The physical distancing and quarantine can lead to poor management of NCDs, as well as exacerbating the NCDs risk factors, such as physical inactivity, tobacco use, and harmful use of alcohol. This qualitative systematic review and thematic synthesis was conducted to assess the challenges that patients and health systems face in the management of cancer in Iran since this pandemic began. We again adhered JBI guideline for qualitative systematic reviews. Our inclusion criteria as participants, we included cancer patients giving services since the COVID-19 pandemic began. Also, studies that included healthcare staff and top managers and policymakers giving care to cancer patients were included. As phenomena of interest, we included studies that described challenges, barriers, and difficulties facing in the cancer care during COVID-19 pandemic in Iran. As the context, we included qualitative studies conducted in healthcare setting in Iran. And finally, as types of studies, we included only qualitative studies with all methodologies and qualitative components of mixed method studies. Also, we included qualitative data reported in the quantitative studies. As you see, we searched these databases. We searched Medline, Embase, PubMed, and other databases for qualitative studies. For data extraction, we used standardized data extraction for JBI, which included items of phenomena of interest, research methodology, context of the study, participants, and study methods. For data synthesis, we used thematic analysis and synthesis, which had 3 stages. As the first step, we read and reread the text to structurally code the text line by line. Then we looked these codes for their similarities and differences and started to inductively grouping them into a hierarchical tree structure. As the final step, staying close to the findings of the primary study, we synthesized them in a transparent way and produced new concepts naming analytical themes. I just want to move to the results section by showing our pre-flow chart. As you see, finally, we included 3 qualitative studies in this review. Also, I'd like to illustrate the main results by showing you 2 tables. In these 2 tables, we summarized the thematic synthesis process. This table shows analytical theme 1. Totally, we had 50 codes in the text. We had 6 descriptive themes, and we had 2 analytical themes. Analytical theme 1 was cancer patients become more fragile in the time of a health crisis, which included 2 descriptive themes of patient care and patient and families' mental impact. And you see the codes in this table too. The analytical theme 2 was organizational structure seems not to be prepared for a public health crisis. This theme included 4 descriptive themes of staff-related challenges, managerial issues, health policy-related issues, and international collaborations. And you see the codes in the text in the table. As limitations of our study, first, we adopted a systematic search strategy to identify all related studies. However, some might have been missed. Furthermore, studies regarding the challenges of cancer management from the viewpoint of health policymakers or top healthcare managers have not been found and included in this systematic review, which was a limitation of this study. As a conclusion, let me sum up my main points. COVID-19 is not the first deadly pandemic, nor the last one it would be. So global attempts should be continued to prevent and control NCDs as the main killer of individuals ever. Also, implementing policies for early detection of NCDs with low-cost efforts should become an inevitable section of a health policy agenda in low and middle-income countries during and after the COVID-19 crisis. Well, that's it from me. Thank you for your attention. If there is any question, I will be happy to answer.
Thank you, Nida. Really interesting review. Have you published it somewhere?
No, this article is in the submission section.
Okay, so we are waiting it.
Thank you very much.
As we have to remember our timetable, we go further, and our next speaker is Fiona Murdoch, and the title of her presentation is Experiences of Conservative Management for People with Spinal Pain. Also, this presentation based on qualitative systematic review. The floor is yours, Fiona. And thank you, Nida.
Thank you. So this is the experiences of conservative management. The experiences of conservative management for people with spinal pain, and it was a qualitative systematic review. And I'm presenting from the School of Health Science, Robert Gordon University in Aberdeen in the far north of Scotland. So considering the authors, Kay Cooper, Lindsey Alexander, the Director and Deputy Director of the JBI, Scottish JBI Centre, and myself, I'm a core member, Fiona Murdoch. And there was no conflict of interest. This was an unfunded project. So the background, it was really driven by a physiotherapy conference, an international musculoskeletal conference that I went to in 2016. And this highlighted really that there was a need to have more qualitative data and a need to understand what the patient experience was. So initially I thought to do on neck pain patients, but then on exploring the data, there wasn't much information on specifically neck pain, so it was extended to look at spinal pain. And if we're thinking about spinal pain, 80% of people at least have this at some points in their lifetime. So lifetime prevalence is 14 to 71% for neck pain and 5 to 75% for back pain. And patient satisfaction is thought to increase by exploring patient expectations on the structure, the process, and the outcomes for their pain management, and also individualizing treatment and health professional initiatives may be an incentive and support to patients. So that's what I was interested in looking at. So my research question was, what are the experiences of patients with spinal pain receiving conservative management in primary care? So considering the PICO, the population, I included in adults over 18 with spinal pain, any gender, ethnic origin or status. The phenomena of interest, there are studies investigating experiences of conservative management of spinal pain. The context was treatment delivered in primary care in developed nations. And the types of studies, qualitative, including phenomenological, grounded theory, ethnographic, and printed in English. So COVID has had an impact in publication. I should say that I work as a full-time lecturer at the university, and I also work clinically. So sort of writing this up with the pandemic strain, I actually do need to update my search, but I'll come on to that at the end with the limitations. But the search strategy we looked at was Medline, Synal, AMED, Embase, PsycInfo, and the Web of Science and Grey Literature, and that was searched between 2007 and 2019, all English publications. Duplicates were removed and titles and abstracts were looked at, and then there was a full text screening by 2 independent reviewers. So the data extraction participants were patients with spinal pain who were consulting osteopaths, physios, GPs, or a mix of healthcare professionals. And the meta-aggregation approach, all the quotes for this piece of work were actual patient quotes, so they were unequivocal quotes. So the results. 1,481 relevant studies were found, and 1,430 were excluded. There were 51 full texts that I screened, but 36 did not fulfill the inclusion criteria, So overall, there were 15 papers included in the review, and these were all qualitative studies. 7 were framework or thematic analysis, 3 were phenomenological, and 5 were grounded theory. And the spread was that there were 8 from the United Kingdom, 2 from Australia, 1 from Sweden, 1 from Finland, 1 from Germany, 1 from Spain, and 1 from Canada. So if we're looking at the findings, meta-aggregation resulted in 6 synthesized findings using the JBI method. So the first finding was there was a relationship with the healthcare professional and the therapeutic relationship particularly. So an example quote was, "She examined me very thoroughly. Well, it was fantastic. I experienced that I was really seen." So that was something patients really wanted. The second finding, communication factors, including professional factors, respect and being listened to. It's hard to find a good doctor that pays attention to what the problem is. Finding 3, patient experience and the desire to have an outcome of spinal pain and active empowerment. So maybe more assessment, ongoing assessment would be helpful so I can track my progress. Also the patient influence. So the patient experience and desire to have outcome to spinal pain and active empowerment. Patient experience and empowerment was important there. Finding 5, the impact of spinal pain on daily life, exercise, and the treatment experience. I couldn't drive or straighten up. I couldn't sleep. I've got 2 small children. I was desperate for anything so I could go back to work. And the patient perceptions of spinal pain and continuing with their exercises. The acceptance. Nothing can cure it. I know that it's a problem I have to live with. So as I said before, there were limitations with this review. I'm a clinician in the NHS and private practice and lecturer full-time at the university. So it's impacted on time to write up and publish. But I'm going to do a further search and hope to write this up in the summer. But also it's only English language. So therefore, we missed research in different language. And sorry, the findings will also be graded with Conqual. I haven't done that yet. So we're thinking about further research, further qualitative research across professions and physiotherapy. So profession specific and across professions is needed in spinal pain and in other areas of healthcare. It could link with developing guidelines for spinal pain management. And from a context point of view, it may be interesting to look at if there's region-specific differences with Europe, North America, Australia, for example, because their MSK healthcare systems are quite different. From a conclusion, the experience of patients included in this review really demonstrate a strong patient-therapist relationship. So communication is very important to have sufficient time, empathy, listening and caring qualities. Also, patient empowerment is also influenced by adequate knowledge from that healthcare professional, and this influences their behaviour change and more autonomy of spinal pain. Thank you very much, and that is my contact details there.
Thank you.
And references.
Thank you, Fiona. I don't see any questions or comments, and Unfortunately, we will have to move on.
That's fine. Thank you very much. Thank you.
If you have questions for Fiona, please contact her. Thank you once more. And then Leila Mahadi is our next speaker, and her presentation's title is Improving Patients' Evaluation in Post-Anesthesia Care Units in Imam Reza Hospital in Muscat. This presentation based on best practice implementation project. The floor is yours, Leila.
Hello, I'm Dr. Leila Mashhadi. Do you hear my voice?
Yes, we can hear.
And can you see my slides?
Excuse me?
Can you see my slides?
Yes, yes, yes.
In the name of God. I'm Dr. Leila Mashhadi. I work as anesthesiologist in Mashhad University of Medical Sciences, and I'm happy to be here with you. These are my co-workers and colleagues in this project, and one of them, Dr. Kamran Khazani, is here with me in this presentation. As you know, with recent advances in medical technologies and better understanding of medical conditions, more advanced surgeries are being performed which require proper post-operative management. It is vital to perform careful post-operative assessments and monitoring because complications might occur in the post-anesthesia care unit that we say PACO. These complications could include worsening of clinical conditions, increased pain, unplanned admission to intensive care unit, prolonged hospital stay, and other morbidities or even mortality. Early detection of complications might prevent the adverse events. In the criteria, our audit question in this study was, is the criteria for discharge from PACO correctly used in our hospital? And the aims of this project were, one, to assess PACO nurses' compliance with the post-anesthesia assessment protocols. Two, to evaluate the effect of an educational intervention to improve the knowledge of nurses who work in PACO. All assessments were done for PACO nurses in Imam Reza Hospital, Mashhad, Iran. Imam Reza Hospital is one of the biggest educational hospitals in Mashhad with multiple operating rooms and 16 recovery beds. In the phase 1 baseline audit, a team consisting of 5 anesthesiologists, operating room head nurse, and 3 expert PACO nurses was assessed to perform baseline audit for this study. Based on the opinion of the team members, a baseline assessment performed on 50 patients in PACO. This process enabled the researchers to identify the weak points in PACO nurses' performance. We designed a questionnaire containing the criteria for determination of discharge score for release from the PACO, Aldrich criteria, Marshall criteria. These 3 fields that our expert PACO nurse assessed after our PACO nurses discharged the patients. In the results of phase 1, in the baseline audit, we had 43 assessments in 30 fields. In the field of discharge scoring system, the compliance of PACO nurses with Aldrich criteria was 56%. In the field of assessing pain, conscious state, nasal and vomiting, and blood pressure, the compliance was 58%. Finally, in the field of vital signs, compliance was 58%. Phase 1 results showed that most nurses were familiar with just some parts of Aldrich criteria and other important discharge factors. Briefly, we did phase 1, and all 3 fields had unacceptable results. In the phase 2, the team assessed the baseline audit results. We assessed the shortcoming and POCO nurses' knowledge of audit criteria. We planned an educational session in the OR for our POCO nurses to review the audit criteria. This process took 1 week. The team leader designed the contents of the agreed session using presentation software and reviewed the course with one of the expert nurses. She conducted the class with a POCO nurse, with all POCO nurses present. After the contents of class, audit and monitoring criteria and several voice descriptions were uploaded to a web-based group for further referrals. So after the educational intervention, we did phase 3 as in phase 1. 50 patients were assessed. Similar criteria as in baseline audit were assessed by the expert POCO nurses. This phase took 1 week. As you see, the results of phase 3, in the field of discharge scoring system, the compliance of POCO nurses with discharge criteria was 60%. In the second field, the compliance was 86%. Finally, in the field of vital signs, compliance was 90%. We can say that after educational intervention, we had improvement in compliance of nurses in all fields. But in first field, the difference was not significant. The second and third field, the difference was statistically significant. Considering the results, we understand that not only the intervention caused elevated knowledge, but also resulted in better decision and performance. During this study, we have 3 challenges: COVID-19 pandemic, assessment of POCO nurses interdisciplinarily, hospital accreditation program. We proposed that repeated education in POCO regarding the discharge criteria using intermittent tests and filling paper forms for discharge based on other criteria would be a good strategy to prevent complications. POCO nurses' decision for the correct time to discharge the patients have a significant impact on the patient's further complications. In this study, we released that without continuous education interventions, nurse knowledge will diminish to an unacceptable low level. We recommended that the education to be continuous and supervised by an appropriate team. Thanks for your attention. We are ready to answer your questions.
Thank you, Leila. Unfortunately, we don't have time for questions and comments. Maybe later we have it, but not now. We have to move on. Thank you, Leila, once more. And then,
Thank you. Thank you.
Then we have next speaker, Amin Telepur, whose presentation concerning audit of environmental health status of clinical wards in military hospital in Tabriz in 2020. I mean, you have 8 minutes and now it's your turn. You are welcome.
Hello, everyone. Do you have my sound?
Yes.
Thank you. Do you have my slides?
Yes, we can see.
Hello, everyone. Let me just start by introducing myself. My name is Amin Telepur, PhD candidate in healthcare management. I work in Research Center for Evidence-Based Medicine as a JBI Center of Excellence in Tabriz, University of Medical Sciences. I am very grateful to have this opportunity to present my article with the title Audit of Environmental Health Status of Clinical Wards at a military hospital in Tabriz in 2020. I am presenting this paper on behalf of my experienced colleagues, Dr. Nouri, Professor Haj Ibrahimi, and Professor Tabrizi. There are no conflicts of interest to disclose. This presentation is divided into 5 parts: introduction, aims and objectives, methods, discussion, conclusion, and there will be time for questions after my presentation. Let's begin by introduction. As you probably know, healthcare associated infections is an important cause of morbidity and mortality in hospitalized patients. Recent studies suggest that environmental contamination plays a significant role in HAAs and in the unrecognized transmission of nosocomial pathogens during outbreaks, as well as ongoing sporadic transmission. The persistence of these microorganisms in the environment can serve as a source of transmission and dissemination in the hospital environment. In this regard, controlling environmental factors in order to create a healthy and safe environment for patients and their treatment seems necessary. The aim of this study was to evaluate the effectiveness of a clinical audit as a valuable tool to improve quality of care on promoting environmental health status of clinical wards at a military hospital in Tabriz in 2020. As we will see in the next slide, briefly, the objectives of this study were to determine current compliance with evidence-based criteria regarding environmental health status of clinical wards at a military hospital in Tabriz, to identify barriers and facilitators to achieving compliance, and develop strategies to address areas of non-compliance, to recognize some interventions to improve compliance with the evidence-based criteria, and finally, to improve outcomes. As methods, the present study is a descriptive cross-sectional study that was conducted from October 2020 to March 2020. Data were collected by a researcher-made checklist. After confirming its reliability and validity, this clinical audit involved 3 phases of activity: establishing a team for the project, undertaking a baseline audit based on criteria informed by the evidence, reflecting on the results of the baseline audit, and designing and implementing strategies to address non-compliance found in the baseline audit, conducting the follow-up audit to assess the outcome of the interventions implemented to improve practice and identify future practice issues to be addressed in subsequent audits. Our audit team consists of physician, nurse, and PhD students in healthcare management, the environmental health expert, and the quality control expert. Audit criteria briefly were consisting of needs assessment, training of hoteling staff, monitoring the environmental health status, material supplying, controlling of consumption, suggesting the improvable points, and annually service staff assessment. So what did we find? As you see in this chart, after comparing of baseline and follow-up audit, we found that all of criteria have been improved. On average, percentage of compliance of clinical health status with clinical health standards changed from 58% in the autumn quarter of 2020 to 76% in the winter quarter. What were our strategic and interventions for achieving this improvement? They were increasing commitment of hospital management, designing a weekly washing program, training in the use of disinfections to ward services, improving the physical environment of wards, continuous monitoring of environmental health expert, on-time supplying and controlling of detergents. As discussion, improvement of environmental health status in the short term of the hospital was the result of this study by using clinical audit tool. For continuously improvement of the environmental health status, the use of clinical audit method can be effective. The result of this study regarding the promotion of environmental health in the hospital were similar to other existing studies. According to some studies, doing some activities like developing national policies and applying guidelines and safe practice will decrease the number of infections associated with healthcare settings. As a conclusion, the use of clinical audit tools can lead to the improvement of the environmental health of clinical wards to the up level, and it suggested the use of clinical audit tools as one of the tools for continuous quality improvement for clinical wards. I hope you find my presentation useful. I'd like to invite you any question you may have.
Thank you. I don't see any questions or comments. And due to our timetable, I have to move on. But thank you once more, Amin.
Thank you so much.
Next, we have 8 brief presentations. Each of them is 4 minutes. Please follow our schedule. Actually, we have only 7 brief presentations because I noticed that Donna is not online. But our next speaker is.
I think she's online now. Donna, are you there?
Hi there. Yes, I'm online.
Okay.
She's online. So we have 8 presentations.
Okay, thank you. First, we hear Cristina Costeira's presentation. The title of her presentation is Cancer Pain Management Patients in Portuguese Oncologic Institute. This presentation based on a best practice implementation project. Cristina, the floor is yours.
Thank you very much. Good morning, everyone. So my name is Cristina. I'm a nurse and I'm from Portugal. And in the name of my work team, I would like to congratulate the organization and scientific committee for the event and to thanks for allowing us to present our work that is called Cancer Pain Management Patients in Portuguese Oncological Institute, a best practice implementation project. To start, I would like to declare that I don't have any conflict of interests. This topic is very relevant. Even the World Health Organization considered cancer pain management as a worldwide medical emergency. And we knew that effective pain management is a fundamental step towards the effective humanization of healthcare. Our objectives in the study are to identify conformities between scientific evidence and care practice, to implement evidence-based strategies to improve care for people with cancer pain, and to evaluate the effectiveness of implemented strategies. The project was developed during the years 2020 and 2021 with patients and nurses from a surgery ward of a Portuguese hospital of oncology. We used the Joanna Briggs Institute methodology for implementation projects and assessed 8 audit criteria based in the best practice in cancer pain management provided by JBI. As strategies of implementation, we create 1 pamphlet, 1 cancer pain manual, 2 training programs in cancer pain, and a document to improve nurse records. The results suggest there was a disparity between the care practice offered and the evidence-based recommendation in the first audit. All the audit criteria showed improvement in the outcomes when we made our follow-up audits. So, the results suggest there were, so in conclusion, we outlined, the outlined objectives were achieved. The implemented strategy were efficient in the process of improving the quality of care, since it reduced the difference between what is recommended by the evidence and what is practiced in providing care to people with cancer pain. Thank you for your attention. I hope to fulfill my time.
Thank you, Christina, for your brief presentation with
4 minutes is very
3 minutes.
Very difficult. 4 minutes, it's okay. So if anyone have some question to me, I would love to answer it.
I don't see any questions, but you have very important topic. Maybe later you receive some questions or comments.
Thank you very much.
Then Maria Teresa is our next speaker, and her presentation's title is Pain Assessment and Management on Persons Unable to Self-Report. Also, this presentation based on an implementation hospital project. The floor is yours, Maria.
Hello, everybody. As you said, as Aria, my name is Maite Roldan Chicano, and I work as a nurse in a hospital in Cartagena, in Spain. Well, in elderly patients with dementia, pain is frequently underdiagnosed and therefore undertreated. Assessment and management of pain, RNAO guide, recommend perform a comprehensive pain assessment on person unable to self-report using a validated tool. Hospital General Universitario Santa Lucía in Cartagena, in southeast of Spain, was selected as an applicant best practice spotlight organization. Strategic objectives and priorities to meet project requirements have included a wide variety of action directed to get a right assessment and management of pain in hospitalized patients unable to self-report. In a first phase, a literature search in Medline, MBES, and Synthesized provided validated tools. Secondly, the tool was selected on a consensus building by the modified Delphi technique. 8 professional nurses with more than 10 years of experience in clinical setting participated. 2 rounds of questions were performed and an expert group answered blindly. The selected tool was integrated into the digital records and hospital protocols. A training program about the correct use of the tool was carried out among professionals. Finally, the implementation of the tool was evaluated through a descriptive quantitative analysis. The literature search in databases provided 34 pain assessment tools for patients unable to self-report their pain, of which only 5 were linguistically and culturally validated in Spanish. Algo Plus scale received the best score using the Delphi method of consensus. Ease of use was the most valued quality, even more than discrimination capacity. Algo Plus evaluate the presence of 5 items: facial expressions, look, complaints, body position, and atypical behaviors. An assessment can be completed in less than 1 minute. For patients with acute pain conditions, the score is 2 or bigger. The tool was included in 3 forms in the digital records: vital signs, work planning, and Gordon's functional health patterns. The score of Algo Plus was integrated into the care planning so that from a score 2 or higher, the activity pain management of the nursing intervention classification taxonomy is automatically recorded into the activity program. In the last phase or audit phase, 155 nursing professionals participated in an on-the-job training program. Infographics and dissemination through social networks were also used. To determine the level of implementation of the tool, more than 36,000 pain assessment records dating during the period June 2019 to April 2021 were analyzed. A total of 7,822 records, 21% of the pain records, were made using the Algo Plus tool. Patients had an average age of 69 years, and the distribution of the use of the tool by sex was very similar. The increased use of Algo Plus scale occurred mainly during and after training in the workplace. The percentage of use of Algo Plus suffered ups and downs during 2022 due to COVID pandemic, although it had less fluctuation than EVA scale. After the third and worst peak of COVID cases in our hospital, dated from December to February 2021, the use of Algo Plus scale have increased again in April, obtaining the highest percentage of use. These are our conclusions. Implicate professionals with extensive work experience from the beginning of the tool selection process is a successful strategy. Easy and speed of use are especially valued features in clinical settings with a great care pressure. Thank you for your attention.
Thank you, Maria. And we move on. Next, we have Donna Winnes' presentation, and her title is Student-Led Rehabilitation Groups and Clinics in Entry-Level Health Education. Her presentation based on a scoping review. Donna, it's your turn.
Thank you. Can you see my slides?
Yes, we can see.
Thank you. Good morning, everybody. My name is Donna Wynne, and I completed the scoping review alongside Professor Kay Cooper, and we're from the School of Health Sciences, Robert Gordon University, Aberdeen. This scoping review looked at student-led rehabilitation groups and clinics in entry-level health education. Brief background is that student-led groups or clinics are a mode of healthcare delivery in which healthcare students take primary responsibility for organising or running a healthcare service. Key drivers include supporting underserved populations, an altruistic approach and provision of free or pro bono services, and substitution of clinical placement hours. The objectives of student-led learning in this context are to target skills development and experience real-life healthcare with populations and conditions. The review questions were to identify, map, and describe the characteristics of student-led physical rehabilitation groups and clinics in entry-level health education. This included the types of student-led groups and clinics, the characteristics of such groups, how those student-led groups and clinics are evaluated and what outcomes are used, and who was evaluated and how were those evaluations undertaken. This scoping review was conducted in accordance with the JBI methodology for scoping review and in accordance with a previously published protocol. It had a 3-step search strategy in which 6 databases and 3 grey literature sources were searched, with 2 independent reviewers and co-evidence utilised to facilitate screening. Allied health professionals and sports students who participate in physical rehabilitation in student-led groups were the main population, with the context being developed nations and any settings for the groups or clinics at all from community, hospital and university. Just a brief overview of search results. We started with 608 records, and through the PRISMA process was narrowed down to 48 studies being included within this review. Key results are as follows. So of the student-led groups, there were 4 main areas in which students participated in these. 16 interprofessional student-led groups or clinics. There were 2 that had a sports science student. 4 had occupational therapy students. And the biggest number was 26 with physiotherapy students. And that from the sources and literature, there were 3 key aims of student-led groups and clinics, which were student skill development, social enterprise and altruism, as well as replacement of clinical placement hours. The population served by student-led groups and clinics are shown per country. There were 6 main countries in which student-led groups and clinics are run, with the USA being the most popular. And across the populations, this ranged from the general public to community partners, older people, those with neurological conditions, and by far the biggest number of people who attended student-led groups and clinics were the underserved or uninsured from the public. The main pattern of delivery was for the replacement of clinical placement. Some student-led clinics occurred as part of an academic module, and others, a smaller number, occurred out with academic modules. In conclusion, student-led groups and clinics are very different stages of development and use within entry-level curricula. The objectives and drivers for groups and clinics varies immensely globally, and therefore the evolution of such groups and clinics have driven a wide and varied number of models. Recommendations for further research are to further evaluate student experiences in relation to specific stages of the curricula, evaluate outcomes for service users, as well as further explanation of perceived satisfaction, and need to further understand the impact of student-led groups and clinics on entry-level education for whom and where they might be of most benefit. Thank you for listening.
Thank you, Donna. Next speaker is Hassan Soleimanpour, and he has a presentation which title is Evidence Implementation Report Basic Life Support Training for Nursing Working in Intensive Care Unit of Imam Reza Hospital in Tabriz. His presentation based on a best practice project. The floor is yours, Hassan.
Hassan, we cannot hear you.
Is Hassan online?
He's online, but he has not the microphone open. Both the microphone or the... I think he was trying to share a presentation, but maybe we can leave it for the end. Maybe if he's having any trouble with that, and we can move to this one and leave it for the end.
Okay. So maybe later he will available. And we move on. Next speaker is Katharina Johnson, and the title of her presentation is Manual Patient Handling in the Healthcare Setting. A presentation based on a scoping review. Katharina, the floor is yours. Nice to see you.
Hello, can you see my screen?
We can see this and we can listen to you.
Okay, perfect. Well, good morning, everyone. I'm Katharina Johnson. I'll be presenting the scoping review on manual patient handling in the healthcare setting. I'm a doctorate of physiotherapy student at the School of Health Science in Robert Gordon in Aberdeen. Just to get started, there was no conflicts of interest for this scoping review, and it was unfunded and formed part of a larger doctoral research degree. The background of this area: healthcare practitioners often perform moving and handling treatments and movements without using any assistive devices or technologies. These manual tasks increase risk of injury to staff and contribute to high numbers of sickness and staff absence from work. In addition to this, allied health professionals also utilise therapeutic handling with patients to further aid their rehabilitation in their inpatient stay. So going from this, we wanted to investigate what the current evidence base was in this area. And then a bit more specifically, we wanted to investigate the primary research in this area, specifically what questions had been addressed, what populations had been investigated, the settings the research had been conducted in, what aspects had been explored in moving and handling, and outcome measures, techniques, or technologies that had been used in this area. To do this, we followed a JBI guidance for scoping reviews throughout, and we searched 5 databases and 5 grey literature sites. We focused on literature published after 2002, as this is when a significant piece of moving and handling literature and guidance in the UK was updated, and we included literature published in English, focusing on healthcare practitioners performing the task in any healthcare or laboratory setting. And we included a wide variety of research types, from primary research of all types to educational resources, to allow us to have a wide range map of what was conducted in the area. For the results, it was quite a large number of results included, with 41 in the scoping review. 1 was a systematic review, 30 were primary research articles, and 10 were other evidence types, such as educational pages for staff, ergonomic assessment tools, or narrative summaries of government guidance or statistics. From the primary research, we found that observational cross-sectional study types were the most common, likely because it's the easiest to perform in this kind of setting, with nurses being the most common staff population investigated. And most of the research was conducted in a laboratory setting, and in these settings, healthy volunteer simulated patients were used rather than real-life patients. And joint angles and physical demands of moving and handling were the most common outcomes measured. So going from this, we concluded that it needs to be more research focused on allied health professionals, as they weren't investigated as much, including a bit more focus on the joint angles and forces involved with the therapeutic handling. There's currently no real guidance on this area, so more needs to be known. Also linking what is taught in moving and handling training and how that kind of correlates to what is executed in practice would be important to know. Also further qualitative research focusing.
Mehdi, could you please turn your microphone on? Mehdi, could you please turn your microphone on?
I think we're good now. Yeah, so also further qualitative.
Hello everyone, I'm here.
Yes, please wait a while. Wait a while. It's Katharina's presentation.
And finally, just some further qualitative research focusing on both nurses and allied health professionals, with consideration for barriers and facilitators to allow us to have a more comprehensive understanding of what people do with manual patient handling in healthcare, and just to improve the safety of it and reduce injuries with our staff members. Thank you for listening. If you have any questions, feel free to contact me.
Thank you, Katharina. And our next speaker is Hassan, if he is online already.
Are you there?
Okay, then we go on, and our next speaker is Lindsey Alexander, and the title of her presentation is Exercise Therapy for the Treatment of Tendinopathies, something I don't understand, and the presentation based on a scoping review. Lindsey, nice to see you for a long time. The floor is yours.
Thank you, Arya. Nice to see you. I am just going to pop this up into full screen. Has that gone into a full screen for you all to watch? see. Hello, can everyone see this? My screen share. There we go. All right, thank you very much, everyone. I'm presenting today on the exercise therapy for the treatment of tendinopathies, which is a scoping review we've carried out as part of the first stage in an NIHR-funded project, which is being led by Professor Kay Cooper. And that's through the School of Health Sciences in Aberdeen at RGU. In terms of declarations, the only one we have to say is that it has been funded by the NIHR, but we have no other declarations to state. To set the scene for you, tendinopathy is a common musculoskeletal condition affecting many tendons in the body, and exercise is the most common non-surgical treatment for it. But what we identified at the start of this large project was that there was a need to map the evidence to inform the subsequent evidence syntheses that were planned for the project. So our question to start off was, what evidence has been reported on exercise interventions and outcomes for the treatment of tendinopathy? Our methods was using JBI scope and review methodology. Participants were any age, gender or tendinopathy. Experience, the concept was exercise, which could be delivered by any professional, and also outcome exercise. Sorry? Oh, okay.
Please continue.
Yeah, the context was in any setting, but we limited it to high human development countries to be relatable to the UK setting. You can see we had a range of sources we searched, quite a large time frame to look at, 1998 onwards, 3-step search strategy. We spent time developing an iterative data extraction tool, and our synthesis was guided using ICON and tidier checklists. So results for this, we had over 22,500 sources and studies identified. We ended up after screening with 555 sources, which represented 119 systematic reviews and 436 primary studies. Of the primary studies, there were over 25,000 participants with a broad mean age range from 15 to 65 years. There were 4 main tendinopathies identified in the results: the rotator cuff, Achilles, patellar and lateral elbow. And the main exercise reported was strengthening exercises, followed by flexibility, and then less commonly motor control, stability and proprioceptive exercise. To just touch on some of the results, because this is a huge scoping review and we don't have time, the reproducibility of these exercise interventions was of interest to us using the tidier checklist. And as you can see here, very few were fully reproducible from the graph, which is the grey, and that was across all tendinopathies. In terms of adherence, which is hugely important for exercise, this was only planned in 35% of the primary studies. And then of those that planned, only 20% in total of all the studies reported it. And this was qualitatively via participant self-report. And the adherence averaged about 77%, with a lot of varied subjective ratings across excellent and poor. No standardization in that. Outcomes, disability was the most common health domain investigated for rotator cuff, Achilles and patellar, and physical function capacity was the most common for lateral elbow tendinopathy. And there were a range of common outcome tools used across all tendinopathies. To conclude for that, this is a large but first comprehensive map of exercise for tendinopathy and the outcomes reported. It's huge. We have identified a number of research implications, as you can see here. We've also pulled together, as this is the second large scoping review we've undertaken, some top tips to consider whilst conducting reviews of this size, because it's a skill in itself as well to make sure that you're ending up with on-time delivery and comprehensive delivery of what you've found. So thank you very much, folks. Any questions, please contact me via this. There we go.
Thank you, Lindsey. And do we now have Hassan online? Yes, we have. It's your turn, and his presentation title is Evidence Implementation Report, Basic Life Support Training for Nurses Working in Intensive Care Unit. So the floor is yours, Hassan.
Are you there? I don't see him connected. I don't know. Yeah, he's connected, but he's. Charlie? I think now he has the microphone open. Yeah, we can see you.
Yes.
Yeah. You
Can I start? Thank you. Hello, scientific committee and respected audience. My name is Hassan Soleimanpour, professor of emergency medicine and critical care from Tabriz University of Medical Sciences, Iran. My project title is about improvement basic life support training for nurses working in the ICU of Imam Riza Hospital, Tabriz, Iran, a best practice implementation project. This project is guided by Professor Haj Ibrahimi, respected Director of Research Center for Evidence-Based Medicine, a JBI Center of Excellence, Tabriz University of Medical Sciences. I really appreciate her for her support in the establishment of JBI course in Iran. I declare there is no conflict. I declare there is no conflict of interest in this project. Firstly, I have a brief introduction about this project. The total number of sudden cardiac arrests in population above 35 is 1 out of 1,000. The process of medical education in the field of CPR depends on several issues such as training materials, students, professors, educational field, and the applied technologies. There are no exact statistics about successful rate of CPR in Iran. However, according to available studies, 9.7% of medical staff are familiar with CPR guidelines. There was no clear evidence on how education should be structured. The authors reported a critical need for further high-quality research to be conducted in this area. E-learning is a novel method in medical education. In recent years, its implementation in medical education system is suggested and practiced. In this study, we aim to assess the ICU nurses' performance regarding BLS after interventional e-learning and maintain-based education. Therefore, based on the above-mentioned information regarding importance of BLS training in the medical staff, especially in the ICU, we intended to use the clinical audit model approved by the Australian JBI to evaluate and upgrade the using of credible evidence in the basic life support training for nurses working in the ICU. Our audit questions. Our audit question, what are the main problems and their best solution, the main barriers to implementation, combat them, and the main outcome regarding improvement basic life support training for nurses working in the ICU. Our specific objectives were to determine current compliance with evidence-based criteria regarding BLS knowledge and performance, to identify barriers and facilitators to achieving compliance and develop strategies to address areas of non-compliance, to improve knowledge regarding best practice regarding BLS among ICU nurses, to improve compliance with evidence-based criteria regarding knowledge and performance of BLS to improve outcomes regarding ICU nurses. Our methods were based on 3 phases of activity. Phase 1 is team establishment. Phase 2 were design and implementation of the strategy to improve practice. Phase 3, follow-up audit post-implementation. In the current slide, you can see our hospital, our team, and our ICU staffs. Our audit criteria were based on the Australian GBI criteria. Our results in the phase 1 or baseline audit is the aggregated data collected from the ICU 7 ward demonstrated that criterion 1 to 4 and so 8 had the highest percentage of compliance out of the 13 criteria. This criterion measured the compliance of nurse education occurred in 100 of the sample. Overall, there were 8 out of the 13 criteria that had less than 50% compliance. In the phase 2, we determined barriers, then we provided a strategy. Our barriers were as following: insufficient education tools, insufficient education program, insufficient supervision, lack of skill lab in hospital, lack of continuous BLS education. And our strategies were as following: providing human stimulator mannequin, providing education program, establishment of CPCR department in the hospital, establishment skill lab in the hospital, and continuous medical education based on the AHA guideline. Our follow-up in phase 3 demonstrate that our compliance in all our criteria increased up to 100% successfully. Although the barriers implementation were challenging, our project showed improvement for each criterion in the follow-up clinical audit. To improve compliance rates, we needed cooperation between intensivists working in the ICU and key person directors, head of skill lab, head of ICU, head of hospital, deputy of research and educational of hospital, head of nursing office in the hospital, and ICU supervisor. Initial and ongoing education of the nurses has been the most important challenges of this project. The result of this implementation project indicate that clinical audit is an effective approach to assessing evidence-based education regarding improvement basic life support training for nurses working in the ICU. Finally, we would like to acknowledge the dedicated team members involved in this project for Imam Reza General Hospital, Tabriz, Iran. Also, they acknowledge Research Center for Evidence-Based Medicine, Tabriz University of Medical Sciences, Tabriz, Iran, a GBI group for their appreciated scientific support. Thank you for attention.
Thank you, Hassan. And we have to move on. And please, your presentations inside 4 minutes. Our timetable is really tight. Mariam Soleinpour's title of presentation is Falls Prevention among Psychiatric Patients in Raji Hospital in Tehran. This presentation based on a best practice implementation project. It's your turn, Mariam.
Hi, everyone. Could you hear me?
Yes, we can hear you.
Yes, this is Mariam Soleinpour. I have participated in the symposium from Research Center for Evidence-Based Medicine, Iranian EBM Center, JBI. There is no conflict of interest, sorry. Yes, there is no conflict of interest in this project. And our project topic is promoting falls prevention among psychiatric patients in Razi Hospital, Tabriz, Iran, a best practice implementation project. Falling is a main priority in healthcare system, as we know, and the number of patients fall in inpatient psychiatric units is higher than medical surgical areas, as you see, and this risk is not age-related. And falls can lead to injuries, increased lengths of hospital stay, reduced quality of life, and etc. A quality improvement project from ONES examined the effect of a fall risk and prevention agreement between the nursing team and older adults showed decrease of 37% in falls. And a systematic review with awareness investigated the effectiveness of patient-centered intervention on falls prevention in acute care hospitals. Of the 5 included RCTs, 3 showed a reduction in fall rate. And our audit question was that if we can improve fall prevention among psychiatric patients with the implementation project, the key aims of this project were to determine current compliance with evidence-based criteria, to identify barriers and facilitators, to improve knowledge, to improve compliance with evidence-based criteria, and to improve outcomes. 3 phases of our activity were establishing a team reflecting on the result of the baseline audit and designing and implementing strategies and conducting a follow-up audit. That was done in Razi Hospital in Iran, and our sample was 15 patients. With the 11 audit criteria, as you see in the table from JBI, and the result of the 11 criteria are shown in figure in the baseline audit. That these criteria measured for risk assessment on ward transfer 87%, and patient participate in the for risk assessment process 95%, and for risk status revision if patient fail only 50%, and care management plan reviewed, and the rate of the education among healthcare professionals is 78%. We have 5 barriers, and because of that, educational session, dissemination, and implementation of the protocol was held to increase compliance of for risk assessment on ward transition, perform full prevention protocol for at-risk patients, and announce all nurses of second barrier, and provide educational session about the importance of patient participation in the for risk assessment and prevention protocol by experts. And healthcare professionals were given more information about the fall prevention protocol via formal meeting. The result of the follow-up for each of the 11 criteria are shown in figure, and there is a 3% increase in the for risk assessment on ward transfer from transfer, and 1% increase in patient participate, 36% increase in revision patient for risk, and 8% increase in healthcare professional education. This project showed improvement for 4 criteria in the follow-up, but 6% decrease in patient engaged in goal setting and treatment planning shows us one of the limitations of our study, that is psychiatric situation of our patient. Half of the elderly people who fall will have more falls, so 36% increase from in revising patient fall risk statute. In patient that fail is a great success that can't be ignored. And the literature and the clinical audit outcome show a good adherence to evidence-based recommendation. Finally, preventing and reducing falls is a quality imperative. In order to achieve such a goal, it is necessary to repeat and continue the training. Thanks for your attention.
Thank you, Marianne. And now our last speaker is Mehdi Nouri. His subject is clinical audit of hemovigilance, something like that, compressed red blood cell product in 2019. Please, Mehdi, the floor is yours.
Hi, everyone. Hello.
Hello.
Let me start.
You have to share your screen, please. Your presentation.
Do you have my sound?
Yeah, that's right. We hear you and we can see your slide, so you can start.
Good morning, everyone. Let me just start by introducing myself. My name is Mehdi Nouri, PhD candidate in healthcare management. I work at a military hospital in Tabriz University of Medical Sciences, and also I work in a research center for evidence-based medicine as a JBI Center of Excellence in Tabriz University of Medical Science from Iran. I'm very grateful to have this opportunity to present my article with the title of Clinical Audit of Hemovigilance Standards in Hospital using WHO framework at Military Hospital of Tabriz, conducted 2019. I'm presenting this paper on behalf of my experienced colleagues, Dr. Taleppour, Professor Haji Ibrahimi, and Professor Tabrizi. My presentation is divided into 5 parts as introduction, aims and objectives, methods, discussions, and finally conclusion. There will be time for question after my presentation. There are no conflicts of interest to disclose. As you know, blood transfusion is most important issue at hospitals that can be caused to improve patient safety and quality improvement, and finally patient satisfaction in hospitals. The aim of this study was to clinical audit of hemovigilance standards in hospital using World Health Organization framework at Military Hospital of Tabriz, conducted 2019. This study have 4 objectives, such as determining current compliance with evidence-based criteria, identifying barriers and facilitators, organizing some intervention, and finally improving outcomes. This study was a qualitative studies as action research study and quality improvement program study that was conducted on 2019. We done this study on 124 patients of military hospital, was audited over a period of 4 months. We use the most important 2 tools for data collection, such as observations, nursing in wards, and using the standard checklist as a WHO checklist for hemovigilance standards. But the main part of this study using a clinical audit cycle, such as establishing a team for the project, that multidisciplinary teams help us to implement this project. Another baseline audit, as you say, we use hemovigilance standards, checklist, and after that implementing strategy, and finally follow-up audit and we are important finding this study, I say briefly, the percentage of compliance baseline of standards from 70% to 79%. In overall performance of nurses in fields of blood transfusions was at good level, but this hospital has four main lower than standards, such as laboratory equipment and staffs and transportation from blood banks to clinical departments need to be improved and upgraded. But there are 6 important strategies done this hospital as I think the most important one, commitment of hospital management, very important parts to improve this standards. Another that education healthcare professionals and monitoring of nurses' performance and preparation of laboratory equipment and educational posters. And finally, documenting and reporting of cases with defects to hospital manager. This study, such as other studies, were done in the world that using of clinical audit can be improved the standards. Our studies findings showed and similar to other studies in the world, and for continuously improve the process of hemovigilance, these tools, I mean clinical audit, should be used continuously with the participant of process owners. And finally, the conclusion part, the use of clinical audit can lead to improvement of all of the process in the hospital and could be improvement quality and safety in all of the clinical wards. Thank you for attention. I hope you have found my presentation useful. Now I'd like to invite any question you may have.
Thank you, Mehdi. I don't find any questions, so I'm ending this session. Dear colleagues, in this session, 7 presentations describe different types of reviews. 6 presentations covered implementation and 2 audit projects. Once more, thanks to all speakers as well as the audience. Now we have a break, and during this break you will have the possibility to visit the poster exhibition. I wish a nice summer for all of you. Thank you.
You will be able also to look at the posters, and you can ask questions to the posters authors in the chat. Okay, and they will be able to. People, well, the authors of the posters will be available for answering questions in the chat during the break, and then, as you know, at 1. We have a final conference that you will go to the website and join the final conference.
Around.
Okay. No, I'm sorry. I'm sorry. You can go on. Please excuse me. You can go on.
Oh, budur bu. Bu bizim için budur var mı?
Remember, please, that the final conference will take place at 1, and you will have to move to the final conference room at 1. And you can watch the posters in the web page of the event.
Hello. Yes. Can you hear me? Okay. It's a question for Laura Lafarga. The poster, I'll try to see, is risk of delirium among elderly patients in internal medicine wards, a best practice implementation project protocol. Hello? Oh, sorry. I would like to know how the group select the audit criteria.
Sorry, can you repeat the name of the poster? The title?
Yes, the title was Risk of Delirium Among Elderly Patients in Internal Medicine Wards, a Best Practice Implementation Project Protocol.
Yeah, that poster belongs to the Spider Multiplier Event exhibition room. It's from room 2, I think.
Okay, sorry.
And the author of the posters are not online available as panelists. They should answer the questions using the chat, as we were saying before. For posters, you should use the chat for asking the questions, and the authors will answer using the chat also.
Okay, thank you. Sorry.
Don't worry. Thank you.